Okay, great. Okay, so we have no disclosures. Today we're going to be talking about management of co-occurring alcohol use disorder. Really, it's management of alcohol use disorder, namely in the primary care setting, but also in the context, just to keep in mind, of co-occurring opioid use disorder when folks are on treatment for that. And I apologize if I don't see a chat or any comments coming in. I will try to pay attention, but I think my colleagues will as well. So thank you in advance. So the objectives today are to learn the signs and symptoms of alcohol withdrawal syndrome and how to properly manage it, and to become familiar with FDA and some off-label, but FDA-approved medications and psychosocial interventions for the treatment of alcohol use disorder. So let's just start with a case to kind of frame this. Your patient, Ms. A, is a 41-year-old female with a history of hypertension and opioid use disorder who presents to clinic for a routine follow-up on her blood pressure. She's been taking her buprenorphine, her hydrochlorothiazide, and lisinopril, and she tries to follow a low-sodium diet and regular exercise routine. She quit smoking tobacco 2 years ago, but she does report daily alcohol use. And on physical exam, her blood pressure is a little up at 154/98, and the rest of her exam is normal. So you are concerned about her blood pressure, and could it be that it's uncontrolled due to her alcohol use? And how do we determine if she has a pattern of risky drinking, or does she have alcohol use disorder? So we're just going to review some definitions briefly. So remember, again, in the US, the standard drink in the US is equal to 0.6 fluid ounces or 14 grams of pure alcohol. And just to kind of have a visual here, again, and this is important when you're just asking questions about how many drinks a day, to make sure that we're framing this in terms of the standard drink size. So that would be, for instance, 12 ounces of regular beer. And you can see across there, the wine, it would be 5 fluid ounces. And so you want to ask about the size when patients are reporting their amount of drinks. So what is risky drinking? So the National Institute on Alcohol Abuse and Alcoholism defines these as the following quantities. And these would be for people to fall into a low risk category. This applies to adults who are not pregnant. So for women, no more than 3 drinks in any given day, and no more than 7 drinks in 1 week. And then for men, no more than 4 drinks in 1 day, and no more than 14 drinks in 1 week. And it's important that we screen for this so that we can make sure that we're intervening if there is a pattern of risky use. And Esprit has been shown to be very effective for this. So the USPSTF gives a grade B recommendation to screen for unhealthy alcohol use in adults, including pregnant adults, and provide brief intervention for those who we do identify as engaging in a risky or hazardous drinking level. And this has been, it is grade B, meaning that it can be covered by Medicaid and Medicare. It can be administered in a variety of settings by a variety of health professionals, but this evidence is strongest for this in primary care, that we use the 5 A's approach to ask, advise, assess, assist, and help arrange for help if needed. And these sessions can be really brief, lasting anywhere from 50 to 20 minutes. And the goal is to reduce the negative consequences of use. And really, this has been shown to be most effective before a use disorder has developed. We may find people with that when we're screening for sure, but we want to intervene even before that occurs. And we can start screening for risky drinking and alcohol use disorder with a single question. And this initial approach has been shown to be very effective. This is also a single question approach that we use for screening for all substance use. For alcohol, we will ask, how many times in the past year have you had 5 for men, or 4 or more drinks in a day, to really recognize if there's sort of a binge use pattern. And if the result is positive, then we would move on to our more specific assessments. So assessing the severity and risk for alcohol with the audit C, or other validated method. The audit C, I'll show you in a minute. That one's a pretty quick and easy way to assess. The MASG, just to mention, is particularly sensitive for the geriatric population, and CRAFT, I'll show you here in a minute, is more geared towards our adolescents. So we want to make sure that we're choosing an appropriate screening method. Here's the CRAFT. So for younger children, you might consider a lead-in about friends use, just to kind of make it a little less abrupt. Avoid ambiguity though. So really just asking straightforward, during the past year, did you drink any alcohol? And any youth with a positive answer should be asked the following questions. So CRAFT stands for, have you ever ridden in a car driven by someone using? Do you ever use alcohol or drugs to relax? And do you use alcohol or drugs alone? Do you ever forget things while using? Have your family or friends, so 2 F's here, told you to cut down, and have you gotten into trouble while using? So back to your patient here today, she responds yes to the first question that you asked about alcohol use, and you administer the audit C, and she scores a 7. We'll look at that in a minute. And then on further discussion, you also learn that she has significant fear of stopping due to prior episode of withdrawal 2 years ago. And that reserved those symptoms was resolved when she returned to alcohol. You also note that alcohol is interfering with her home life and work, and she asks for your help. So these things are part of the criteria that we'll go into for an actual diagnosis of alcohol use disorder. But here's your audit C, so you can see these 3 questions and what she circled. And so how often do you have a drink containing alcohol? She circled 4 or more times a week, so she scores a 4 on that one. How many drinks containing alcohol do you have in a typical day when you're drinking? So she scores a 1 because it's 3 or 4. And how often do you have 6 or more drinks on one occasion? That's monthly, so she scores a 2. So you can see here what the score of at least 4 is identifying. For men, 86% in that risky category. For a score of over 2 identifies 84% of women. And so this is going to be a useful tool moving forward in our practice. So for diagnosing alcohol use disorder, how do we know if your patient needs treatment for AUD? And really, we're looking again at these criteria that we see for other use disorders. But one way to think of it is at least 2 of the 11 criteria may be grouped into the 3 C's of cravings, compulsions to use, and consequences. And then certainly tolerance and withdrawal are 2 of those criteria. So once you have assessed for that and made your diagnosis, what treatment can you offer? So just to touch upon treatment rate, sadly, only it's pretty low. So only about 7% of adults, 5% of youth with AUD in the past year received treatment. Less than 1 in 10 people in the US with a diagnosis, and we see this with opioid use disorder as well, but with a diagnosis of AUD in the last year received treatment of any kind. At least 90% of community programs offer only group counseling and referral, and so that is sort of indicating a lack of comfort with prescribing medications for this. And then importantly, there are still sadly many barriers for racial and ethnic minorities to both mutual help groups and in general, these groups experience lower treatment utilization, especially by women. So certainly something that we have a lot of work to do on. Here's our treatment options for AUD. And I'm just going to pause and see. Yeah, thanks. Checking the chat. So the 2 main aspects when someone's presenting in your clinic is kind of assessing for acute withdrawal and appropriately addressing that, and then addressing relapse prevention. And both can be done in the initial visit, but sometimes we're, especially in more emergent situations with withdrawal, we may be moving on at a future visit, but we want to try to make the most of that first visit. So just briefly, if someone's in acute withdrawal, we're determining whether they're appropriate for an outpatient management of that versus inpatient based on their risk and severity of withdrawal. If we are seeing them as okay to proceed with outpatient, we are providing most likely a brief benzodiazepine taper to help get them through that with close follow-up. And we may consider gabapentin or carbamazepine to help with symptoms as well, but not the benzodiazepine taper would be specifically for seizure prevention. Then we're going to mainly focus in this talk on relapse prevention. So what are our FDA-approved medications for this? And we'll go into these. Naltrexone, which in someone who we're also prescribing buprenorphine to would not be an option, but we'll go through this as well. Acamprosate would be an option. Disulfiram, not a whole lot of evidence for that. That's anabuse. And then some off-label ones are gabapentin, baclofen, and topiramate that have some evidence of effect. This is kind of small on the screen here, but this is just an example. This is your CWA scale. This is often used inpatient to help monitor someone and dose them appropriately when they're in withdrawal, but we also use it in the outpatient setting, and you can see that this is their assessment for withdrawal based on subjective, mainly objective findings. And really when someone's scoring of 15 or higher, they're definitely going to be needing medication. When they're over 18 to 20, we are looking at inpatient, although as many of you know, this can oftentimes be difficult, but it is most times warranted. So again, for managing withdrawal, 2010 Cochrane review of 64 RCTs showed that benzos are effective. So really effective treatment to help prevent alcohol withdrawal seizures when compared to placebo. There was insufficient evidence for the use of anticonvulsants. Carbamazepine may be more effective in treating some aspects of alcohol withdrawal, and it may also help decrease drinking extent after the initial detoxification period. And there may be a role for gabapentin in mild withdrawals. This is what our large body of evidence, this is the summary of that. So we see our patient, again, in our clinic. Her CWA is a 12, so not too high. She doesn't have a history of head injury, seizure. She's not pregnant. She has support at home. And we review options and determine that she is a good candidate for an outpatient taper. And we discuss the risks of this and agree with that decision. So she does return after a successful taper, but she has strong urges to drink. So this is a case where we are seeing her back promptly in order to help prevent relapse with in other medications and therapy. So what medications can you offer? So again, this isn't going to be particular to this patient because she's also on buprenorphine, but our first line medication in general that we're going to talk about is naltrexone. This is our opioid antagonist that works at the same receptor as the buprenorphine does, right? And so for alcohol use disorder, it's been shown to be very effective, both in the pill form and the extended release form. And it blocks the effects of endogenous opioids that are released by alcohol consumption. So it basically is going to help block that reward sort of pathway to decrease the chance of an extended relapse if someone were to have a lapse to alcohol. Again, it's contraindicated in someone on opioids due to it being an antagonist and precipitating withdrawal. We do need baseline liver function tests. It is metabolized by the liver. And as long as it's within 3 to 5 times the upper limit of normal, keeping in mind what that is for a man and a woman on your lab, in your lab results, we can start it, and sometimes we'll just monitor it more closely. Again, we're weighing the risk of being on that with the risk of continued alcohol use to the liver. And a Cochrane review of 50 RCTs, 7,700 patients showed that oral naltrexone decreased the relapse to heavy drinking to 83% of the placebo risk with a number needed to treat of 10, and decreased drinking days by 4%. And heavy drinking days by 3%. So all of these things are helpful in terms of counseling our patients and explaining the benefits of potentially being on a medication each day. And naltrexone has a the largest body of evidence here in the US, the combined study being the one that most are familiar with. It's the largest controlled pharmacotherapy clinical trial for treating AUD. It was conducted at 11 sites in the US, and it was randomly assigned patients to placebo plus minus acamprosate, which we'll talk in a minute, and or naltrexone, all with medical counseling, so medical management in the visit with their provider. And half of the patients, though, received up to 20 CBI sessions in addition. And what the study found was that those with the naltrexone and medical management alone, and those with placebo plus the CBI had the most substantial decrease in days drinking. So this is really what's referred to in terms of primary care management, of really trying to get patient on the naltrexone in the outpatient setting, has been shown to be very effective. Acamprosate has a little less evidence of effect, but may still be helpful for many individuals. Has a totally different pathway in terms of its physiology of how it works. So it's an amino acid derivative that increases GABA transmission, and it's thought to stabilize the glutamate receptor. It has a strange dosing schedule of 666 milligrams, so 2 big tablets 3 times a day, which can be hard to follow. Some people may divide that into 3 tablets twice a day instead. It is not metabolized by the liver, and we need baseline kidney function tests. And a Cochrane review of 24 trials of nearly 7,000 patients showed that it decreased the relapse to alcohol when compared to placebo, with a number needed to treat of 9. It's not included on this slide, but it seems to be most effective when started once someone's been off of alcohol for at least a couple of weeks. And its most important role appears to be in preventing relapse in someone. Well, there it is on that slide. I guess I just didn't break down the amount of time in someone who's already abstinent from alcohol. And then just briefly, because this is our other FDA medication, but we rarely use it unless someone is specifically requesting this medication, disulfiram, and also if they have good support and perhaps someone to help them dose it. This is the one that causes a disulfiram ethanol reaction, so people will feel horribly sick if it comes into contact with any alcohol, and needs strict monitoring of liver function. It's really contraindicated if someone doesn't have a goal of total abstinence and can't be started within 48 hours of the last drink. And again, it has limited trials supporting its efficacy. Likely, if there is efficacy, it's best when taken with direct observation or type of supervision. And then just briefly to talk about some off-label use of medications that may be helpful. Topiramate has some evidence, 7 RCTs that show more days abstinence and less frequency of binge drinking than placebo. This is one we just need to counsel on the side effects, and women absolutely have to be on birth control. It can start, though, we'd start at low and work up to weekly as long as it's tolerated, the goal dose being 100 milligrams twice a day. And gabapentin also has a body of evidence that showed effect on the percentage of heavy drinking days. Target dose for this was 12 to 1,800 milligrams a day. And we do need to be cautious as it has a potential in some cases for misuse, and is now, I think, on actually PNP as a result. So the current APA guidelines are that naltrexone or acamprosate would be first line for treatment of moderate to severe AUD. And suggest the use of topiramate and gabapentin in patients who have AUD, but usually after first trying naltrexone or acamprosate, and they may be combined with one of those if needed. And disulfiram should not be first-line treatment. So how do we decide which medication to take or to prescribe? You certainly want to consider their coexisting medical comorbidities. So we talked about the hepatic, liver, and kidney clearance. We want to ask about prior experiences with treatment. Something may have worked well in the past, so that would be good to try perhaps again. What about ability to take medication at a certain frequency? If it's really hard to, acamprosate is less likely a good one. And certainly you may also look at the potential for the injectable naltrexone if they're not on opioid agonist or partial agonist. considering their psychiatric comorbidities and the need for treatment of those as well. So we also want to make sure that we aren't neglecting something that may cause someone certainly to drink or to self-treat with alcohol. There was a one trial showing that there was a significantly higher rate of abstinence in folks who had co-occurring major depressive disorder and AUD when they had naltrexone and sertraline than when they were prescribed either alone. And one quick question for the group is, and you can either put this in the chat or just sort of think to yourself, what should we do with our patient here? When we're prescribing, she's been really stable with her OUD on her buprenorphine prescription, but what do we do with that prescription if she has ongoing alcohol use, sometimes heavy alcohol use? What would you guys suggest? And I can no longer see the chat for some reason, but I'm just gonna let you ponder that. So we want to continue to prescribe her buprenorphine. It would be more harmful to her to withhold it, but we want to increase support, and that can involve increasing visit frequency as well. Certainly want to continue to reassess the effectiveness of our treatment for her alcohol use and adjust that as needed. And just remember to periodically monitor her liver function, certainly if we're seeing concerning alcohol use, that's something that we don't want to forget to assess. And just to touch upon as well, some of the behavioral interventions for alcohol use disorder that show very good evidence, and that can be, depending on your treatment setting, offered or if possible referrals placed for patients. So again, just the brief intervention that we discussed earlier, meta-analysis of 34 studies, over 15,000, showed that those receiving that brief intervention ingested about 1.5 standard drinks less than those in the non-intervention group after 1 year. So remember, that's really important, like especially early on, if there's any high risk drinking noted. There was little difference shown on the frequency of drinking or binge days. And the features of this intervention include feedback, responsibility, providing advice, providing a menu of options, and showing empathy and supporting one's self-efficacy. And typically this leads to a 20 to 30% reduction in heavy drinking, with significant effect found for up to 2 years. Certainly, motivational interviewing has a vast body of evidence. Over 32 studies have shown benefit of this in treatment of AUD, and it's found to be most effective in the first 3 months with younger populations. Occasional heavy drinking, but low clinical dependence. And then certainly mutual help or AA groups. This has been shown to increase days off alcohol at both 3 and 15-month follow-up. However, the Cochrane review of 8 trials didn't show evidence of efficacy on its own as a standalone. And then family involvement, if this is possible, if this is a positive thing for your patient, being able to get their support can be very beneficial in some instances. So this has been shown to reduce drinking in 5 trials. So to close our case, we obtained our baseline renal function tests as our patients on buprenorphine. We opted to start ecamprosate. We started her at 1 tab 3 times a day, but really as long as she's taking that okay, it's fine to just go right up to the full dose of 2 tablets 3 times a day. She also agrees to meet with our clinical psychologist for CBT. After a month of follow-up, she reported that she had 1 lapse last week with 1 glass of wine, 5 ounces, but this didn't lead to a full extended relapse, and she hasn't had any alcohol since then. Her blood pressure also happily has normalized, and while she screened positive for depression, we discussed adding sertraline to her regimen, and she reports improvement in her mood and her length of time off of alcohol. So in summary, we want to screen our youth and adults for AUD on a routine basis using those validated screening tools, be able to diagnose risky drinking and intervene hopefully before we see development of AUD, but also be able to diagnose AUD and treat this promptly. Remembering that it's one of the most undertreated health conditions in the US, however, it continues to account for significant morbidity and mortality. We want to assess withdrawal risk and recognize the need for inpatient versus outpatient management, and then feel comfortable counseling patients regarding the different treatment modalities for alcohol use disorder, and prescribe indicated medication or refer for other supportive treatment. So with that, I'm going to stop the share and see if there's any questions or comments.